I invite chairpersons Dr. Prashanta Dihingal from Dibrugarh and Dr. Varsha Babu. Sir and ma'am, please come on to the dais and take your seats.
Dr. Vijay Prasanna is there?
Ma'am.
Actually, so whom to introduce?
Yeah, you carry on. You introduce the speaker.
But I need the details.
First speaker, Dr. D. Iracon here. She's talking to us about vaccination and new norm of life.
In RMDs, Indian data. Welcome.
At the outset, I would like to thank the organizers for this opportunity. The vaccination of rheumatic patients has become increasingly important in recent times. The vulnerability to infections among rheumatic patients has increased because of so many reasons, which include aggressive use of immunomodulators as part of diet control strategies, increasing use of small molecules and biologics, etc. Presence of comorbidities like COPD and diabetes mellitus further amplify the risk. India being a tropical country, there is a high prevalence of infectious diseases. Patients have more chance of acquiring secondary infections. Also, infection is a major contributor of mortality among rheumatic patients. And the present figures of mortality and morbidity may still move upwards with more aggressive line of management, including biologics, being likely in future. So the role of preventive vaccination has more relevance among patients with rheumatic diseases. But vaccinating rheumatic patients has certain problems to overcome. The decreased immunogenicity due to defective immune function due to disease and immunosuppression caused by DMARDs. And the vaccines can induce a flare of disease due to the extrinsic antigen stimulation and due to the presence of adjuvants in the vaccine. These are the vaccine preventable infections which occur more commonly in patients with rheumatic patients. But unfortunately, adult immunization in India was not given much importance. The concept was attached with it controversy and lack of consensus. In 2009, the Association of Physicians of India came up with guidelines for adult immunization, in which the influenza vaccination against influenza, pneumococcus, and herpes zoster were not recommended due to lack of adequate published data in Indian population. Ramesh Sharma and colleagues in 2015 stressed on the importance of adult immunization in India. Following this, so many articles were published in the Journal of UP and our Indian Journal of Rheumatology, starting from Professor Handa and Vinita Shobha and Sham Shantana, all emphasizing the importance of vaccination in rheumatic patients. In 2017, this excellent article published in Indian Journal of Rheumatology dealt with all aspects regarding how to handle disease-modifying drugs during vaccination, the population to target, and how to time the administration of vaccines, etc. Coming to the general principles of vaccinating rheumatic patients, the vaccine should preferably be administered when the disease is quiescent and preferably before the start of immunosuppression. Live vaccines are generally avoided for patients on immunosuppression. Whereas non-live vaccines can be administered during therapy with glucocorticoids and anti-rheumatic drugs. Though the immune response is little blunted while being treated with these agents, existing literature suggests that still vaccination is likely to confer adequate protection. Coming to the impact of anti-rheumatic drugs on the immune response to vaccine, the greatest blunting of immune response is seen with rituximab, followed by abatacept and methotrexate. TNF inhibitors, in contrary to the expectation, are less likely to interfere with the immune response to vaccines, except in the case of hepatitis B vaccine. So to optimize the safety and efficacy, The factors which need to be considered before vaccinating rheumatic patients are: 1, the level of disease activity, and 2, the level of immunosuppression that the patients are in, and the timing of administration of the vaccine. So let me take up the individual vaccines. Coming to the influenza, the commonly used influenza vaccine is the trivalent inactivated vaccine. The best time to vaccinate is before the onset of monsoon in around April to May in most parts of India, and in the extreme north and southern regions like Kashmir, Chennai and Kerala, the ideal time is around September to October. Coming to the impact of anti-rheumatic drugs on immunogenicity, methotrexate, rituximab and abatacept have been shown to decrease the immune response to influenza vaccine in varying degrees. So except these drugs, other drugs can be continued if the disease activity requires. Coming to the pneumococcal vaccine, currently 2 pneumococcal vaccines are available. The pneumococcal polysaccharide vaccine 23 induces immunological memory which is not long lasting, so boosters are required. The pneumococcal conjugate vaccine induces memory which is long lasting, so it's, a single dose is sufficient for the lifetime. So for rheumatic patients on or contemplating starting immunosuppressive therapy, pneumococcal has been, vaccination has been recommended by all the rheumatologic societies. The general rule of thumb in the case of PPSP 23 is for patients more than 19 years and less than 65 years of age, a total of 2 doses should be given at a minimum interval of 5 years. After the age of 65 years, a single dose is given. And in case of PCV 13, a single dose is sufficient for lifetime. The US Advisory Committee on Immunization Practices has recommended the administration of PCV 13 first, followed at least 8 weeks later by the PPSP 23. The approach being called the prime and boost strategy. If the vaccination commences very early before the age of 65, a second booster of PPSP 23 after 5 years has to be given. And after the patient crosses the age of 65, a final booster of PPSP 23 is given. But in India, the PCV 13 was not approved for adults till 2012. So many patients had got vaccinated with PPSP 23 as their first pneumococcal vaccine. So for those patients, PCV 13 has to be given at least 1 year after PPSP 23. Coming to the impact of drugs on immunogenicity, rituximab to a greater extent and abatacept to a comparatively lesser extent blends the immune response to pneumococcal vaccine. So these drugs have to be stopped and other drugs can be continued during the pneumococcal vaccine series. Hepatitis A vaccine should be given to at-risk adult patients who have not been vaccinated. For rheumatic patients, completing the 2-dose series at 0 and 6 months is important to ensure enough seroprotection. Coming to the hepatitis B infection, for rheumatic patients, both the ACR and EULAR recommend hepatitis B vaccination only for patients at risk. But in India, the scenario is different. Because the lifetime risk of developing chronic hepatitis B vaccination is high, it has been integrated into the universal immunization program in line with the WHO recommendations. The ACIP in its 2022 update also recommends HPV vaccination for all patients less than 60 years of age, regardless of risk. And this is the schedule being followed. For rheumatic patients, if the immunization status is not known, it is advisable to do the serologic testing. Patients are considered to be immune if they are hepatitis B surface antibody positive, either by natural infection or by vaccination, depending on the hepatitis B core antibody positivity. Patients who are hepatitis B surface antibody negative are considered to be non-immune and have to be vaccinated. Following completion of vaccine, antibody titers have to be checked. For those who fail to seroconvert, repeating vaccination may be needed. Coming to the impact of drugs on the immunogenicity, TNF alpha inhibitors severely dampen the immune response to HPV vaccine. All rheumatic patients should receive tetanus toxoid vaccination in accordance with the recommendations for the general population. Both RA and SLE patients, including those on the disease-modifying anti-rheumatic drugs, both conventional and biologic, show satisfactory immunogenicity. Though there is no data on the efficacy of TB vaccination under B-cell depletion therapy. Based on the data extrapolated from other vaccines, it is assumed to be decreased. So in high-risk cases like those with major or contaminated wounds who received rituximab in the last 6 months, it is safer to administer tetanus immunoglobulin. The HPV vaccination is particularly important in SLE patients because SLE patients are at a higher risk of contracting genital infection, particularly with high-risk serotypes associated with cervical cancer. Moreover, it has been found that there is the rate of spontaneous clearance of infection is less in SLE patients. All these facts highlight the need of vaccinating all SLE patients against HPV. So, the Indian Academy of Pediatrics in 2016 advocated routine vaccination against HPV for all between the age of 9 to 14 years and catch-up vaccination up to 45 years. The same has been recommended by the IJR article. But the advisory committee in its update in 2021 recommends administration of HPV 2 doses at 6 months interval between 9 to 14 years. From the age of 15 years and for the immunocompromised individuals, 3 doses with varying schedules for bivalent and quadrivalent vaccine have been recommended. In India, apart from the 2 vaccines that have been already available, the Cervavac manufactured by the Serum Institute of India has been recently approved by the DCGA. So coming to the herpes zoster, the incidence of herpes zoster is high among patients with rheumatic diseases, and particularly after the arrival of tofacitinib, the incidence has become much more, and special concerns are being raised. There is an increasing demand to vaccinate patients against herpes zoster before initiating therapy with tofacitinib. So zoster vaccine, being the live vaccine, is generally avoided in patients being treated with steroids, conventional synthetic DMARDs in the doses mentioned here, TNF inhibitors and B-cell depletion therapy. There are 2 zoster vaccines available. The Zostavax is a live vaccine. It is administered as a single dose. Whereas a Shingrix is a non-live recombinant subunit vaccine with a T-cell boosting adjuvant. It is likely to be safe in patients on immunosuppressants. So, till the year 2021, the rheumatology societies have recommended zoster vaccination for patients more than 50 years of age who have never had herpes zoster or had herpes zoster more than 5 years back. And this is the recommendation on the management of disease-modifying drugs during and after the administration of zoster vaccine. For conventional synthetic DMARDs, the whole time of 1 week is recommended. For biologics, the whole time of 1 dosing interval is recommended by the Indian authors. But the recent 2022 guidelines by the ACR and US ACIP, the target population has been extended to include rheumatic patients more than 18 years of age. And the vaccine they recommend is a recombinant vaccine. But unfortunately, recombinant vaccine is not available in India. Efforts are being taken to make it available by next year. So this is the ACR 2022 guidelines on the management of immunosuppressive medications during live vaccine administration. Glucocorticoids, conventional synthetic DMARDs have to be held for 4 weeks before the administration of live attenuated vaccine. JAK inhibitors have to be held for 1 week. All the biologics except rituximab have to be held for 1 dosing interval. Rituximab ideally 6 months. For IVIG, it depends on the dose ranging from 8 months to 11 months. The whole time after the administration of live attenuated vaccine is uniformly 4 weeks for all the molecules. So in those patients where the risk of adrenal crisis is high, glucocorticoids can be used up to the dose of 30 mg per day. And in patients where the risk of disease flare is high, these hold times can be relaxed, can be shortened. Patients with splenectomy or hyposplenism have to be vaccinated against Haemophilus, influenza, meningococcus and pneumococcus. Much has been talked about the vaccination against SARS coronavirus, so I don't want to go into detail. With this I conclude and thank you all for the patience.
zoster vaccine. Is it available? And it's a single shot vaccine, but it believes it changes and does not give lifelong immunity because the virus.
The vaccine offers protection up to 4-5 years only.
4-5 years.
The immunity substantially declines in 10 years. But it's given as a single dose. Booster has not been approved.
So it's available in your country?
Live vaccine is available.
Still available now? It's available.
Live zoster vaccine is available.
Yeah.
Apart from herpes zoster, which are the other live vaccines which are advocated to be given for these patients? By the way, Shingrix stall is there. There's launching the Shingrix in February.
Okay.
Can you come again?
Sorry, the other live vaccines which need to be given apart from the herpes zoster.
Varicella vaccine can be considered under special circumstances.
Okay, thank you, Doctor. Please wait in case.
From Pune. He's going to give his talk on traditional Indian medicine and rheumatic diseases with evidence, placebo, and the nocebo effects. Over to you, sir, Dr. Wah.
Actually, this is a session style. So I was asked to speak on. I was asked to speak on the traditional Indian medicine and what is the evidence for that. Because it is a lifestyle session, I'll be including only a few plants. I don't think I can cover all of them. So actually, we have a department of Ayush in the government of India, which also includes Unani Siddha and homeopathy. But I'll be talking on Ayurveda only. This is 2015 statistics, which says that there are 7 lakh alternative medicine practitioners, whereas the allopathic practitioners are between 11 to 12 lakhs. So you can understand the significance of these drugs being used by general people. So, simple things used in our kitchen. The first thing is ginger. Actually, in osteoarthritis pain, there is a meta-analysis published in osteoarthritis and cartilage. There are 5 RCDs containing 593 patients, comparing oral ginger treatment with placebo, which had shown significant pain reduction and significant reduction in the disability. The authors then finally conclude that ginger was modestly efficacious and reasonably safe for treatment of osteoarthritis. But they find that the evidence is of, whatever evidence was there, is of moderate quality, based on the small number of participation, small number of patients included, and the ITT intention to treat was not adequately defined. Now there is another study which is recently published in European Journal of Rheumatology, ginger extract suppresses the activity of NF-kappa B and the WNT pathways and protects inflammatory arthritis. This is in animal experiments. You can see how the experimental arthritis how the experimental arthritis patients at the in the arthritis in the control group had the arthritis group had higher levels of IGL, of IL-6, IL-17 and TNF-alpha, and how those on the extract had in them the levels were lower. You can see that 49, 23, etc. Excuse me, is this working? And these are the histopathological changes. The first one is normal tissue. The first one is normal tissue. The second one is showing all synovitis, and third group is showing decreased synovial inflammation in the ginger group. Now second one is curcuma longa, that is turmeric. In osteoarthritis of the knee, it has been tried in the osteoarthritis of the knee. There was these references are from International Journal of Rheumatology, then Clinical Rheumatology, and from phytotherapy research. There was significant improvement in quality of life and WOMAC scores compared to placebo, and the use of concomitant medication also reduced. Then in 14 studies with 1533 patients, comparable to NHID in inducing VAS, in reducing the VAS and the VAS and the WOMAC score. Oral absorption is poor, hence it is used. It is usually not used as a single drug. So we have one more study in which the turmeric extract was used along with ginger and black pepper in 60 patients of osteoarthritis of knee, and then they observed the decrease in the levels of PGE2 was same as naproxen. The adverse effects were very minor. This is the one, a large meta-analysis of 16 RCTs, 11 comparing with placebo and 5 comparing with NHID, of 16 weeks treatment and 1810 adults. The overall risk of bias was supposed to be moderate. The extract significantly reduced knee pain and improved physical function compared to placebo. Similar effect compared to NSAID. And the adverse events were fewer by almost about 12%, and it appears to be a safe and effective option. There is another study which is published in Rheumatology International 2022 that it is a potent antioxidant and anti-inflammatory. It is not toxic and safe. The authors say that say that it blocks chondrocyte apoptosis and the expression of cyclooxygenase, then EG2, and pro-inflammatory cytokines in the chondrocytes, potentially elevating symptomatic disease. And the anti-inflammatory effect leads to the regulation of pain and improved joint function. The recommended dose is 1 to 2 grams per day. They also suggest that further research is required, especially regarding the long-term usage, the optimal dose, and whether this particular plant has got any preventive role. There are some studies published in RA also. About 51 studies have been 51 studies have been reviewed. 13 in vitro, 37 in animal study, and only one study in human. Again, they say that it has an anti-inflammatory action. So these are some of these are experimental studies. There is another review of 6 studies with over 250 patients with RA, in which they claim that the DAS score, DAS 28 score reduced, VAS also reduced, ESR CRP reduced, and RF also reduced in 6 of 6 studies, and no adverse events were recorded. Another simple plant which we see alongside most of the roads is the residence compounds, that is castor. Root extract in albino rats, they say that it has same efficacy as methotrexate. The arthritis score, of course, this is an animal experiment. And then the leaves and the roots, root extracts, leaves or root extracts are antioxidant, anticonceptive, central analgesic, immunomodulatory, hypoglycemic, antimicrobial, and anti-fertility action. The dose of castor oil is 9 ml, 9 ml to be taken 3 times a day. Versus, this is another study, versus diclofenac, which was administered for 4 weeks. Then, and the effect was same as compared to diclofenac. This amvat, inflammatory arthritis, is like an elephant in a forest. And the Ayurveda says that castor oil is the only lion who can kill that elephant. Amvat gajedrasya shariravarancharinah ekameva anta erandasneha kesari. Then we are nimba. Is there any timer? How many minutes are now?
Just 1 minute more, it's still 3 minutes.
1 minute more? Only 1 minute?
5 minutes.
5 minutes.
3 minutes.
I don't think so. Okay, then the same thing about Nimba. Animal experiments only. This is actually an important one which is used as a vehicle in various compounds. Gulu. Animal experiments have shown it to be anti-inflammatory. It reduces MMP2, then nitric oxide and PGE2, and inhibits activation of NF-κβ. Arvind Chopra and others have undertaken an important study which contained almost 8 plus 3. 8 plus 3 ingredients. In RA studies and OA studies, in RA studies it has shown modest disease modified activity, and in osteoarthritis studies it has shown significant efficacy compared to placebo over 32 weeks. Let me know the time.
Sir, another 3 minutes.
3 minutes, sir.
3 minutes.
Yes.
Actually, Dr. Agarwal's group from USA has this article of 175 anti-inflammatory agents, identification of novel anti-inflammatory agents from Ayurvedic medicine for prevention of chronic disease. And then another article is that chronic diseases, inflammation and spices, how are they linked? These two are important articles. 175 anti-inflammatory agents, I cannot let you know about each of them in this lecture. There are various limitations and possibilities as far as these plants are concerned. So limitations are insufficient and inconsistent evidence based. Then the primary data is of low quality. Many of them are animal studies, and it is likely that there is a publication bias. Although the adverse events were minor, and we need large studies of good quality about adverse effects and drug interactions and other things. But it is simpler to get a drug from something which is known to have say anti-inflammatory action or maybe disease modifying action. So this is known as what is called as reverse pharmacology. Placebo effect, I won't say that using these drugs is a real placebo effect, because there are various factors involved, and it is supposed to be genuine bio-psychosocial social phenomena. The effects of placebo are not same in various disease conditions. Like arthritis, it is a different effect. Depression, there is a different effect. SLE, different effect. Chronic pain, different effect. And all placebo don't have the same effect size. Like in 149 osteoarthritis trial, intra-articular injection was supposed the intra-articular injection of placebo was superior to local placebo, which was superior to oral placebo. So that difference has to be borne in mind. And in alternative medicine or in any other medicine, the various factors on which the placebo effect depends is the patient himself, the practitioner, then the patient practitioner interaction, the nature of illness, and treatment and setting. I am also supposed to talk on the this particular effect, nocebo effect, which means that a negative outcome which is caused by negative expectations. The participants are likely to be educated, usually females, with competitive and aggressive personality. And if you talk something which is not positive, you will have higher nocebo effect, and of course the past experience of the side effect. Now this is my last slide. Ayurveda says that there are four pillars of management: the doctor, drug, nurse, and the patient. And actually, Tarak has said that an angry, adventurous, coward, afraid, and suspicious patient, and one who does not follow the prescription, and the one who doesn't have any confidence in the doctor should not be treated. And for the doctors, treating such patients leads to loss of money, loss of knowledge, name and fame. It leads to upakrocha. Upakrocha means the disappointment of the patient and a blame for the physician who asangram, who is likely to lose his job or who is likely to be punished by the administrators. So that's all. Thank you.
Thank you, Dr. Bhatt.
Thank you.
Thank you. The Kerala oil really works for all pains. It's just not that we are advancing in medicine that we should say that our traditional medicine is not good. So with that, we close Dr. Bhatt's lecture, and the next lecture is by Dr. Paul Lorenzo.
I'd like to thank the organizers for inviting me here to the Iracon. It's my honor to be here. Special mention of Professor Debashish Danda. He made sure we come, so we are here. Thank you very much. So the topic of my talk today is cardiovascular morbidity in gout. Lifestyle factors matter. The outline of my talk is to mention the prevalence of cardiovascular diseases in gout, the biological effects of uric acid on the cardiovascular system, the evidence of gout's effect on cardiovascular disease, morbidity and mortality, lifestyle factors, diet and exercise. I'm going to end with SGLT2 inhibitors and hyperuricemia. So, gout is the most common form of inflammatory arthritis globally. The worldwide prevalence range of gout in the 60 to 69 years age group, which is where I think cardiovascular disease has most importance, is 1.15 to 8.8%. The pooled prevalence estimates were calculated for 5 cardiovascular diseases: myocardial infarction 2.8%, heart failure 8.7%, venous thromboembolism 2.1%, cerebrovascular accident 4.3%, and hypertension, a very high 63.9% of patients with gout are hypertensive. And with the same prevalence studies, they looked into gout and non-gout patients, and they showed that gout patients had a higher risk, whether it's relative risk or a hazards ratio, for having a cardiac event across all the different cardiac events. So for myocardial infarction, the effect size was more than 1 for gout. For heart failure, cardiovascular mortality, atrial fibrillation, and angina. So what is it that uric acid does that increases your cardiovascular risk? And this is just a possible scenario wherein the monosodium urate crystals has some intracellular, monosodium urate has some intracellular effects which cause some systemic effects, such as they stimulate and activate your nuclear factor kappa beta, which increases your cytokines, and this has a systemic effect of inflammation. Your mitogen-activated protein kinases and growth factors cause cellular proliferation. The stimulation of vasoconstrictive substances such as angiotensin II or endothelin causes hemodynamic alterations. And oxidative stress is increased by decreasing the nitric oxide, and this causes endothelial dysfunction. So do gout and hyperuricemia contribute to the development and progression of cardiovascular disease? Knowing this possible mechanisms. And I just came across this review, but it's about 10 years old. And actually what they looked into was they asked the question, was uric acid an independent predictor of cardiovascular disease mortality? And there were 4 trials, 3 prospective and 1 retrospective in this review. And 3 of them said yes, uric acid was an independent predictor of cardiovascular disease, and 1 of them said no. So the results are not too convincing at this point. So does treatment of gout improve cardiovascular disease outcomes? So there are several RCTs, systemic reviews, and meta-analysis that have asked this question. And if you look at the first study at the top, it asks, what is the effect of urate-lowering therapy on the incidence of major adverse cardiovascular events, all-cause mortality, and kidney failure? This was a systematic review of RCTs, and the conclusion was ULT did not produce benefits on the clinical outcomes, including major adverse cardiovascular events, all-cause mortality, and kidney failure. The 2 studies that follow actually asked whether febuxostat was non-inferior to allopurinol with respect to the rates of adverse cardiovascular events, and they both basically said the same thing. There was no inferiority between the use of the 2 with regard to cardiovascular event. And the last of at the bottom of this slide asks, what is the effect of topiroxostat and febuxostat on arterial stiffness, uric acid levels, and blood pressure in patients with hyperuricemia and hypertension? And they used a cardiac ankle vascular index. And this trial did not detect any significant effects of xanthine oxidase inhibitors on arterial stiffness parameters in patients with hyperuricemia and hypertension. Now, here's another study which asked the same question, and does febuxostat versus conventional therapy with lifestyle modification reduce the risk of cerebrovascular disease and renal events in patients with hyperuricemia? This was the free trial. It was a randomized control trial. And the conclusion was febuxostat significantly decreased serum uric acid, which is what we expect, and was associated with reduction of cerebral, cardiovascular, and renal events. So this is in contrast to the first study mentioned above, where this question was answered in the negative. If you look at the Kaplan-Meier curve over a 3-year period, you can see that the hazards ratio of febuxostat group was less than the non-febuxostat group for cardiovascular events. And one more study, what is the incidence of MACE, mortality, total cardiac, and specific cardiovascular events in RCTs testing xanthine oxidase inhibitors against placebo? And this was another systematic review. And the conclusion was purine-like XO xanthine oxidase inhibitors may reduce the incidence of adverse cardiovascular events. So we have studies that say yes, studies that say no, and studies that say maybe. So what are the Rheumatology League saying? The EULAR just says that if you have a patient with gout, then you have to look for comorbidities, obesity, renal impairment, hypertension, ischemic heart disease, heart failure, diabetes, and dyslipidemia. The ACR 2020 guideline, they just give a recommendation that if your patient is on febuxostat and has a cardiovascular event or cardiovascular disease, you might want to switch the patient to another urate-lowering treatment because of that. It was identified that it may be a risk of an acute cardiovascular event. And in 2021, the APLAR guideline mentioned that in patients with asymptomatic hyperuricemia and hypertension, we recommend against using urate-lowering therapy to reduce the risk of major cardiovascular events or mortality. Why? The certainty of evidence was very low. However, the reviewers felt that this was a very strong recommendation. The management principles of gout and cardiovascular disease are the same. treat your gout flares, lower your serum uric acid, provide prophylaxis against acute flares while initiating urate-lowering treatment, optimize dietary and lifestyle factors as appropriate, weight loss, limit your purine-rich food, alcoholic and fructose-rich beverages. Total prohibition of purine intake is not recommended since the impact of the serum uric acid is limited to about 1 milligram per deciliter reduction in a patient who follows a strict low purine diet. And of course, the burden to the patient is great. And lifestyle approaches are adjunctive and not replacement for pharmacologic treatment. So are we barking up the wrong tree on the causality of gout, hyperuricemia, in cardiometabolic or comorbid conditions? Genetic randomization studies suggest that several traits of the metabolic syndrome are causal to serum urate and gout, and not vice versa. So adiposity, insulin resistance, and certain lipid components and triglycerides have found a role in the production of hyperuricemia and gout. So Western lifestyle trends, and here is where we can talk about lifestyle issues. We're now eating more, increased calories, and increased proportion size. Eating worse, we're eating more red and processed meat, taking in more sugar and fructose, moving less. We have more sedentary behavior and decreased exercise. And this has a direct effect on hyperuricemia and gout. These have all resulted in the obesity epidemic and ultimately the metabolic syndrome, which has a lot of cardiovascular components: hypertension, congestive heart failure, coronary artery disease, and I have to mention here diabetes and chronic kidney disease. And the medications that we use to address these different conditions are urate-racing drugs such as diuretics, low-dose aspirin, and some organ transplant medicines. And these all have a mediated effect on hyperuricemia and gout. So the author of this article said that healthy lifestyle changes, even on a relatively smaller scale, holds the power and promise to slow down the worsening global burden of gout and improve gout morbidity and comorbidities. Traditional dietary approach, we're always prescribing low purine diet, but you realize that calories are then obtained from other unhealthy fat, such as trans and your polyunsaturated fat and your sugars. So that isn't really recommended anymore. And there are evidence-based healthy cardiometabolic diets, such as the Mediterranean diet and the diet against or to stop hypertension, called the DASH diet. And these have been shown to have greater sustained weight loss and improvements in cardiometabolic risk. The mean serum urate reduction of 2.1 milligram per deciliter in the Mediterranean diet and 1.29 milligram per deciliter in the DASH diet in those with pronounced hyperuricemia. And mark, they define pronounced hyperuricemia as 7.0 milligram per deciliter or more. So that isn't that high. And these are the diet pyramids for the Mediterranean diet and the DASH diet, which you might want to tell your patients to follow. I hear the DASH diet is actually quite restrictive or difficult to do, but the Mediterranean diet, yes. And at the bottom of this table shows that daily exercise and weight control are very important. So now the last part of my talk is to discuss the effect of sodium glucose transport to SGL2 inhibitors, which are used in the treatment of diabetes, on serum urate levels in patients with and without diabetes. I mentioned this because the causality, as I said, is probably from addressing one of the comorbid conditions of the metabolic syndrome, and by addressing this will also decrease your hyperuricemia and gout. So the question of this study was, do sodium glucose co-transporter inhibitors reduce serum urate levels in patients with and without diabetes? This was a meta-analysis, systematic review. The outcomes were all cardiovascular. So This was the secondary endpoint with the question of serum urate, and the conclusion was SGLT2 inhibitors are beneficial in reducing serum urate in patients with and without diabetes, and they could therefore contribute to the general treatment of hyperuricemia. And the last study, it's on empagliflozin, which is a SGLT2 inhibitor, asked the question, what is the effect of empagliflozin on uric acid levels, anti-gout medication, and gout episodes? And the outcomes of this trial was an RCT with 7,000 individuals, were all cardiovascular, and again, this is a secondary endpoint, and empagliflozin reduced the uric acid levels and the composite of gout episodes and or prescription of anti-gout medications. Apparently, this is a class-wide effect, but the uric acid levels are decreased not very significantly, 0.8 to 1 milligram per deciliter. However, if you read the conclusion, the composite of gout episodes is reduced. It's reduced to about 40 to 50% of acute gout flares. So there must be another mechanism wherein this class of medications are improving or decreasing gout flares. So in summary, uric acid may contribute to cardiovascular diseases and cardiometabolic diseases via impairing endothelial integrity and function, inflammation, and a shared pathology of insulin resistance. The evidence for the causality of gout resulting in cardiovascular disease is still not firmly established, and RCTs and systematic reviews have resulted in conflicting outcomes. The evidence for gout treatment for urate-oil treatment in improving cardiovascular outcomes has showed conflicting results. There is beneficial effect of lifestyle modifications such as a good diet and physical activity to lessen the risk of cardiovascular mortality associated with hyperuricemia, and SGLT2 inhibitors, which have cardioprotective and cardiometabolic effects, have shown to decrease uric acid levels and lessen gout flares. So with that, thank you very much.
Thank you, Dr. Lorenzo. I think you've covered this vast topic from all angles.
Warning for Febusostat. But the FAST trial that was published by the Europeans in 2020 had found no cardiovascular risk. So in your opinion, do you think that the ACR should be changing their recommendation? Because that was shared by you earlier.
Yes, I wanted to share that because I wanted to point out that black box warning. And actually the rebuttal, which was the other trials, proved that it was not effective. It was not a risk for cardiovascular mortality. So if you ask me, I think the ACR should revisit that, because this is newer evidence. So I think they should revisit their recommendation.
My name is Gibson from the UK. Thanks very much for that nice summary. I think you've put the emphasis where it truly belongs, on lifestyle. But there are numbers of investigators who are still very keen to prove that uric acid itself is deleterious. The evidence is based pretty well on laboratory work and animal experiments. But coming back to diet, that's so important. The studies that I've done in the past suggest that gouty patients do eat rather more purines only when you take into account alcohol and beer especially. You didn't put any emphasis on that part of the dietary equation, but it is such an important one.
Thank you. Yes, beer is definitely the highest contributor of uric acid among all the alcoholic drinks. Okay? And if you notice, if you notice the Mediterranean diet, they actually allow a bit of wine. But honestly, I tell my patients, if you want to enjoy a bottle of beer, well, just take your medicine. Because it's almost impossible to tell a 30-year-old man or woman who enjoys beer to stop drinking. It's impossible. So I just tell them, take your medicine.
Sir, it was a nice presentation. What we agree on is that gout is, or hyperuricemia is associated with metabolic derangements. So do we routinely screen for metabolic derangements in patients who present with asymptomatic hyperuricemia or gout? And if found, do you think we should treat them in the initial period of gout treatment? If dyslipidemia or microalbuminuria or anything is found significant in a patient who only presented with gout without risk factors, should we address that issue?
I'm going to answer that safely. If there's no evidence in the patient, if they do not have any metabolic risk, or if they do, well, if they don't have any metabolic risk, then we just treat the gout. But if they do have a metabolic risk, maybe we can do the non-pharmacological treatment first, whatever that be. Okay? I just have to say, so there's really no evidence that hyperuricemia should be treated in a patient without gout and the metabolic risks. We have no evidence for that. I mean, they've been trying to ask for it, but we don't have evidence.
I just wanted to be clear about one point. The person who has got asymptomatic hyperuricemia with no associated comorbidities or risk factors, should we still treat him? Because there may be a risk of future attacks of gout.
So the answer for that is no. There's really no evidence for that. And if you want, the safest treatment would be watch your diet already, as mentioned. Just lifestyle, exercise, and live healthy. That's as far as I would go.
So if the uric acid is say 9 milligram or 10 milligram deciliter, we should not bother about
that's always a question. Is there a cutoff? Is there a point wherein, hey, this guy is asymptomatic, but the uric acid level is 9, 10, 11, or 12? We don't have any data on that. Okay? So if you want to, well, we can wait, but we've been waiting for years for that data. And so I'm still going to say that maybe if they really have a very high uric acid, look for other alternative causes, some malignancy under there, psoriatic arthritis, I think that was mentioned earlier, or some myeloproliferative disorder that may be causing the hyperuricemia.
Last question from Dr. Bhatt.
Actually, we experience in India that we have so many patients of hypertension and diabetes and ischemic heart who are already on aspirin. Now that aspirin is supposed to increase the uric acid levels, and we are always at it is very difficult to ask the patient to stop their aspirin. What would be your advice in such a situation?
Don't stop. Take your aspirin, okay, and then you weigh the risk, and this is cardiovascular disease. They might have a myocardial infarction and just die on you, and you don't want that. So I would probably just advise them, stick to your diet and whatever exercise, and if the patient eventually gets gout, you treat the gout, but treat the cardiometabolic issues.
Thank you, Dr. Any questions for the put together in one session? So,
thank you everyone.
Thank you so much.
Learning, sir, from you. And I can only tell you one last line. Don't treat the lab reports. So best thing is to take a good history and find out what was the cause of his high serum uric acid, because in India during your summer month, because of dehydration too, your uric acid becomes a little on the high side. Thank you so much.
Thank you.